This is a discussion on ischemic heart disease. So when somebody comes into the clinic and they're complaining of acute chest discomfort, sometimes they'll say, oh, I just, it hurt, or they've got pain radiating, or whatever. They got pain in their heart. It's good to have a differential diagnosis, meaning, well, here are all the things it could be, and then you can perform some tests or ask some questions, get a history that can narrow it down to, just a couple of things. So first of all, when somebody comes in with heart pain, thing you're going to think is, well, it could be myocardial ischemia, meaning that their heart muscles could not be getting enough oxygen, and so it's kind of starving. It's going to die for oxygen, meaning that the blood supply, the oxygen supply, is less than the demands of the heart. So I'm just going to kind of talk through onset, duration of these different things that you'd be able to kind of sort through on a differential diagnosis and figure out which one is more indicated based on giving history. So when you give a history to a patient, you're going to ask them, well, when did this start? What did it feel like? How long did it last? Did it go away? That sort of thing. So first of all, with myocardial ischemia, it could be a stable angina, or it could be an unstable angina, or it could be like a Prinzmetal angina, or it could be a full-blown myocardial infarction. Based on the history that they give you, you might be able to discern between those. So if it's a stable angina, then the pain would have been started by physical exertion. So they started exercising or something like that, and then it started hurting. Or it could be by cold or stress. And usually it's going to be like 2 to 10 minutes. They do something, or it's cold, or they're stressed out, then they're like, ow, and then they stop, and then it goes away. An unstable angina, however, first I guess I should explain. A stable angina is basically the blood vessel that's going into the heart is got some atherosclerotic plaque around it, and so it's decreasing the blood flow into the heart. And as soon as you start to exercise, or you're cold, or you get stressed, that increases the oxygen demand on the heart, and that little constricted, blocked up coronary artery is no longer meeting its demands, and so it starts to hurt. But as soon as you decrease that demand again by stopping the stress or the cold or the exercise, exertion, whatever, then your heart's okay again. Nothing died. It's all right. But an unstable angina is scarier, because this is where that atherosclerotic plaque ruptures, and it initiates clotting factors that creates a little thrombi in there, a little like blood clot. And so this is an unstable angina, because at any moment this thing could just totally block off and you have a full-blown myocardial infarction. And that's bad. That's really dangerous. Unstable anginas are really dangerous. So in the case of an unstable angina, this is where the pain, it doesn't go away necessarily when you stop exercising. You give the patient nitrous oxide as well, nitroglycerin. That would just really quickly vasodilate the blood vessels and allow a little more blood to go in there. But unstable angina, it's not as simple as it was with the stable angina. It doesn't just go away when you stop exercising. This is an increasing pattern, so it happens more often, or more pain, and it even happens when you stop exercising with an unstable angina. So now what's the difference between that and like a Prinzmetal angina? Prinzmetal angina is just a spasm. It doesn't have to have an atherosclerotic plaque or a thrombi, anything like that. It's just all of a sudden, for some reason, maybe cocaine use, I don't know, something, doesn't have to be that either. The blood vessel just freaks out and clamps down. And when this happens, you need to give the person nitrous oxide or a calcium blocker drug. Those are ones like Verapamil, or ones that end in ipine. The ipines, IPINES, and that can cause the smooth muscle to relax. So the other thing that can happen here is, okay, so the person had an atherosclerotic plaque, and the atherosclerotic plaque ruptured, and it went into an unstable angina, and now it progressed and blocked off the thrombi totally blocked off the coronary artery, and now the person has a full-blown myocardial infarction, meaning that that tissue in their heart is not getting any oxygen anymore. And typically it's going to be one of 3 blood vessels. I'll explain the different kind of ways this can occur. So it could be the left anterior descending, could be the left circumflex, or it could be the right coronary artery, okay? Or it could be all 3. So there's 2 kinds of myocardial infarctions in general. There's one that's called a transmural infarction, and there's one that's called a subendocardial infarction. A transmural infarction is one where all 3 layers of the heart are affected. Now, if you remember, on the inside of the heart, we call that endocardium. That middle region of the heart we call myocardium, and the outside of the heart we call epicardium. Okay, so transmural means this thing goes all the way through. Just all 3 layers are going to die. Now, as opposed to subendocardial, that means this just goes to, remember the inside of the heart was endocardium? That means it's just right here in that subendocardial region. So just on the lowest region. Let me explain the physiology of what's occurring here. These blood vessels supply oxygenated blood to the tissues of the heart. And they are on the outside of the heart. So the parts of the heart that they supply first are going to be the most external parts, starting with the epicardium. So the epicardium is going to get oxygen first. The next part that's going to get oxygen, not as much oxygen because the first part took most of it, is going to be the myocardium. And the last part that's going to get oxygen, even less, with less preference than the myocardium, is going to be the endocardium. So if something's going to die first, it's going to be the endocardium because that's the last part to reach to get oxygen. And it's possible that the epicardium and myocardium may have taken all the oxygen, and by the time it gets down to the endocardium, that all the oxygen's gone. So, explaining really quickly how this works. Transmural infarction is one where the entire vessel is blocked off. There is no blood going through this vessel. And if there's no blood going through that vessel, first the endocardium is going to die in this region. And you can tell where it is. You can tell which blood vessel has died based on, you know, what the area of the heart that dies, or whether, yeah. So I mean, you could draw a little diagram like this of a heart, and down here, this area, this is usually going to be left anterior descending, and make sure you can actually see what I'm drawing. Okay, good, you can. This area down here is going to be left anterior descending. And I believe this area right over here is right coronary artery. And over here would be the left circumflex. So in the case of a transmural infarction, first the endocardium dies, and then the, I guess they probably all pretty much die at the same time. Then the myocardium dies, and then the epicardium dies. But all 3 layers die because all blood to that particular region goes out. Let's say usually, almost always, it's the left anterior descending to come down the apex of the heart that gets the complete block off. So it'd be this one up there represented in this picture. So usually it's that one. So it would be the whole area that dies. And then you would see, you know, first thing that's going to happen is that when you run out of the glycogen and those sorts of things and run out of the oxygen, the muscle fibers are going to get all loosened because they don't have any more energy. They're going to get kind of wavy and sort of because they've stopped holding on. They can't hold on anymore. They're weakened there. And then after 20, 40 minutes, they die. And the mitochondria, after when they die, it kind of start to swell, and that's kind of a typical thing. And when they actually do die, it'll start to turn this darker color. You can see the tissue grossly; it'll be this darker color. And after after about 12 hours or so, 12 hours to 3 days, somewhere in there, neutrophils, they're always the first guys to show up. Remember, they're those small polymorpho, they've got lots of nuclei in there. They all show up and they start infiltrating into the thing. So if you look at this on microscopic inspection, you would see all these little neutrophils in there, and they're all eating stuff up. And then after about a week or so, the macrophages start to come in. And if you look at this grossly, when the neutrophils get in there, the tissue starts to look yellow in that region, sort of like you'd see a zit would start to turn yellow and pussy. It's kind of like that because all these neutrophils, white blood cells, are going in there. So macrophages now come in, and now that the neutrophils have kind of released all their granules and kind of ripped everything up, and they're tearing up tissue and stuff, getting rid of all the dead stuff, the macrophages are the dump trucks that just clean up all the debris and dead tissue. So that'll be after close to a week or something like that, somewhere in the week range. And after the macrophages, they'll do their job for a while and clean things up. Then you're going to start getting some granulation tissue coming in there, and that's going to be like after a week, maybe 2 weeks. I don't remember the exact thing. I think it's like 10 days or something like that. So the granulation tissue, and this is going to start to change from yellow to red around the border of it. And that redness around the border is the granulation tissue, fibrous tissue, and also capillaries are kind of coming into the area as well because it's supplying it with new blood. This area died because it didn't have any blood, and they're getting new capillaries to create a new blood supply for this little area. And so then it's going to turn all red, sort of like when you get a rug burn or something, when you get that before it scars up, you get that red thing over the top of it. It's lots of little capillaries in there. And that's the granulation tissue forming. Now after by a month, this thing's going to slowly be changed over. It's going to start turning a gray color like you see when you get a scar. And the collagen is going to be dumped in there. And this is going to end up turning into a full-blown scar. And by the time 2 months have gone by, the thing's totally healed. And you look at it in gross examination, it's just this white area because it's scarred over. So that there is an instance of a transmural. But I haven't talked about subendocardial. What's happening with subendocardial? Well, subendocardial is a little bit different. Subendocardial could be caused by a couple different things. It could be that it's mostly occluded, a little bit of blood's getting through there. Let's say it's just enough blood for it to supply, just barely enough for it to supply this outer region, and maybe some of this region here, the epicardium, the myocardium, but not quite enough oxygenated blood is getting through to supply the subendocardial region. And so what dies? The subendocardial region dies. So that's why they call it subendocardial. But oftentimes it's not just one, it'll be more than one. So like this one too, this one's also just not quite getting enough blood. And so this region's getting oxygenated blood, and this region's getting oxygenated. But down here, this is just isn't quite getting oxygenated blood. So the subendocardial region. And the same thing here. This region's getting oxygenated blood, and this region's getting oxygenated blood. But just down in here, it's just not quite getting oxygenated blood. So they call it a subendocardial infarction, myocardial infarction, because the subendocardial region is the part that's dying, where there was enough for these outer two regions. And further along with that, sometimes this can be caused by hypovolemic shock. Think about it. If there's not enough oxygenated blood really getting into the heart, it's not even that it has to be occluded. It's just there's not enough blood in there. Same thing would occur. There might be just enough to supply this region, but not so much this region. So hopefully that kind of breaks up the different patterns with myocardial infarction. But going back to our history and all that stuff, usually this is going to be more than 30 minutes. So if a person says, I've had this pain, it lasted more than 30 minutes, we're getting in the myocardial infarction range. Because that tissue can stay alive without oxygen for less than 30 minutes, but it starts getting past 30 minutes, it's going to die. Irreversible damage. Next, you ask the patient about the quality. In the case of myocardial ischemia, with whether it be a stable angina, unstable angina, myocardial infarction, principal angina, whatever it may be, they might describe feelings of pressure and tightness and squeezing, or heaviness or burning, feel like someone's sitting on their chest, those kinds of feelings. And what about the location? You ask them, well, does it hurt here, or where exactly? And they're going to say, the description should fit kind of retrosternal. Okay, so here's the sternum, so just behind their sternum. And often they might even say that pain is radiating. It hurts so bad, it's radiating up into my neck, on my jaw, and my shoulders, or even going down in my arms. And sometimes they might even say that it feels like it's going down in the epigastric region, back behind their stomach. Probably wouldn't use that word though, because nobody uses those words except for doctors. And then you might ask them, you might listen and see if you see any of the features, with your stethoscope, and you find, maybe looks like they have an S4 gallop. Okay, so remember there's those different heart sounds. There's the S1, the S2, and sometimes you can hear an S3. Well, sometimes you'll hear an S4. That's pathologic. So in this case, you hear an S4 sound, the S4 gallop, and that would be pathologic sound. And really quickly, as I'm talking about that, you remember each sound is associated with a different myocardial event, and just want to pull up really quickly and describe those different events that are occurring with that. The S1 sound is going to be closely linked to or rather closely linked, it is the event of the aortic valve opening, okay? And we got to remember, though, the aortic valve and the pulmonic valve both open at the same time. So here's a inaccurate mechanical sort of aid in thinking of this. Okay, so you've got right atrium, right ventricle, left ventricle, and coming in here, the blood comes into the atria. Blood comes into the right atrium from the superior vena cava, from the body. It's deoxygenated. It travels down through here, through the tricuspid valve, and it comes into the right ventricle. And then during systole, the right ventricle squeezes down this valve, the tricuspid valve. This is the same thing that's going on here at the same time. But anyway, tricuspid valve shuts, and the pulmonic valve opens, and the ventricle squeezes the blood down into the lungs, goes into the lungs. This is kind of the lower pressure circuit here. Goes into the lungs, gets oxygenated, and then the blood dumps from the lungs into the left atrium. Once it goes in the left atrium, fills up all nicely in the left atrium, and then it goes from the left atrium through the mitral valve down into the left atrium, and once the left atrium down into the left ventricle, and once the left ventricle gets it all filled up, this mitral valve shuts, systole occurs, which is squeezing systole, and the blood gets pumped from the left ventricle through the aorta into the body. Okay? So you got to realize what's occurring here. Left atrium and right atrium fill at the same time. Okay? And then the blood fills through here into both ventricles, right ventricle and left ventricle, at the same time. And then right ventricle and left ventricle squeeze. So this filling, the opening, when everything was relaxed before it squeezed, it's called diastole. Diastole. It's like it's died. It's relaxed. It's just filling up. I was trying to think of a way to help you remember that. And then when they squeeze down, squeezing systole, both ventricles, right ventricle and left ventricle, squeeze at the same time, and both the tricuspid and mitral valve will shut at the same time. S1. That's the first heart sound. When that closes, that's like a snap. Okay, snaps. That's S1. Okay, these ones shutting, and blood is going to get pushed at the same time into the lungs and into the body at the same time. That's S1. S2 is going to be when the aortic valve. Oh, sorry. Goodness gracious. I apologize. The S1 sound that I was saying was actually S2. I got thrown off. Sorry. S1 is when the aortic valve opens. S2 is when the aortic valve closes. Okay? I apologize for that. So S1 was when this thing opened up. So yeah, when it squeezed. Did I say that right? Forget whatever I said before. I can't remember which one I said. S1 is when these ones squeeze down and this opens. Okay? So that's going to be the first sound. I think that is what I said. I'm sorry. It's early in the morning. So S1, these things squeezing, these guys opening. When these open, the pulmonic and the aortic valve open, that's S1. S2 is going to be when the aortic valve ends up closing. So it's going to stay open until it squeezes all the way down, gets all the blood that it can out, and then at the very end, it's going to go whoop, and it's going to snap closed, and that's your second heart sound. Now, your third heart sound is going to occur a little while later. That's going to be basically when blood is from diastole, just sort of dumps in here, and it kind of bounces off these walls and makes a little bit of sound in the atria, okay, during diastole. Usually, I don't think people usually hear that sound. And if there's a fourth pathologic sound, that's going to be the case of something you would hear in the case of that myocardial infarction that I was talking about, the S4 gallop, or it could be the mitral regurgitation that's occurring here. So mitral regurgitation. Let me talk about these valves for a second, so that kind of makes sense. So stenosis is when it has to strain to push through a tiny little valve. So normally these valves are supposed to open and they're supposed to close, okay? And when they're closed, they're supposed to stay closed, and when they're open, they're supposed to stay all the way open. But if a valve doesn't open up all the way, just opens up part of the way and squeezing through there, that's stenosing, okay? It's stenosed valve. It's stenosis is the word they use, all right? So it's not opening all the way. Now, if it doesn't, and then when it closes, it's supposed to close all the way. But if it doesn't close all the way and it opens up a little bit, that's called regurgitation, okay? So problems opening all the way is stenosis, and problems closing all the way is regurgitation. And stenosis causes the heart to have to push really hard to get all of the blood through a tiny little opening that's not opening up all the way. And regurgitation is when the blood is coming back into that area again, depending on whether it's tricuspid, pulmonary, mitral, or aortic, because it's not closing all the way. So I'll give you a quick example. So normally, when the right ventricle and left ventricle squeeze down during systole, the blood is all the blood is supposed to go through the aortic, pulmonic valves. Not all of it. I guess there's some left over, but it's not supposed to go back, that's for sure. Through the aorta, through the pulmonic valve, into the body or into the lungs. But if there's regurgitation in the mitral valve, when systole occurs and it's supposed to be squeezing the blood through the aortic valve, some of the blood is going to go back up into the left atrium. And that's bad. You don't want that. That could cause left atrial enlargement, and that's a pathologic condition. You don't want that to happen. So basically, there's so much pressure here on this left ventricle. Most of it's going through here, but some of it's squeezing back up into this thing, and that could be part of that S4 sound that you hear. Because remember, S1 sound, this one's opening up, blood squeezing through here. S2 sound is going to be when this guy shuts, and then as this thing starts to squeeze down, or squeeze all the blood out, you hear this, S4, whatever. Okay, so sometimes you hear an S3 or rails if it's severe ischemia or complication of myocardial infarction. Okay, so so we talked all about it. We've really gotten a differential diagnosis for ischemic heart disease in relation to myocardial infarction, in relation to angina, stable, unstable, and Prinzmetal. Next, we're going to talk about pericarditis, but I think I'm going to close this video because it's long enough, and we'll explain that on the next video.